Good afternoon. Welcome to our eco session for the day. I'd like to ask our Eswatini Hospice at Home team to introduce themselves before we continue with our introduction.
Good evening, colleagues. My name is Eswatini from Hospice at Home.
Thank you, Nduduzo.
Good evening, colleagues. My name is Liana Kumaro.
Good afternoon, colleagues. I'm Past Kumar, based at Eswatini Hospice at Home.
Afternoon, colleagues. I'm Sandile Mahlangu from Eswatini Hospice at Home.
Good afternoon, colleagues. I'm Kennington Lamin from Eswatini Hospice.
Thank you for introducing yourselves, colleagues. Can we also introduce ourselves? Maybe I will start with Trustee Bata. Please introduce yourself.
Afternoon, colleagues. I'm Trustee Mbata at Sun, Swaziland.
Thank you, Trustee. Can we have Zinhle?
Afternoon, colleagues. My name is Zinhle Ngwenya. I'm a psychological counselor from Ministry of Health.
Thank you for joining us, Zinhle. Can we move to Magezodwa Kamete?
Afternoon, colleagues. I'm Zota Kamete, working at Eswatini Hospice at Home. Thank you.
Thank you, Mari. Can we also have Malaika?
Hello, everyone. I am Malaika from Eco India. I'm executive in Eco India. Thank you.
Thank you. Thank you for being with us, Malaika. My name is Mercy Shabangu from Eswatini Hospice at Home. I will be the facilitator for today's session. I hope that I'm audible to everyone. So before we continue with our session, just a quick reminder that we should be mindful of background noises. So we suggest that we probably silence our gadgets and remain muted during the session. And if there's anything that we would like to comment or communicate during the course of the session, we can use the chat box as already indicated. And we can also use the raise of hand or even unmute when given the platform or the opportunity to communicate anything to the team. So last week we were looking at prescribing practice and opioid conversions. And today Mr. Mahlangu is going to continue with advanced conversions and opioid side effects. But we are going to conduct our session in a slightly different manner today. We will start with our case presentation instead of our didactic presentation. So at this time, and also to remind you colleagues, it's already written in the chat box that may we introduce ourselves on chat as well. So at this point, I will give the opportunity to our HOHO Regional Palliative Care Nurse, Eswatini, to take us through today's case presentation. Thank you.
Thank you, Mercy. Good evening once again, everyone. Presenting is Eswatini. Our case, fortunately or unfortunately, we have done one visit, so we are hoping that with your contribution, colleagues, we will be able for the second visit to be able to attend to all the client's issues holistically. So our client is a 27-year-old male who has advanced, is HIV positive, so he has advanced disease. Sorry, colleagues, let me display just a second. All right, thank you, Mr. Mahlangu. So as I was saying, our client is a 27-year-old male who's HIV positive. Our client was born HIV positive, hence I've written the eugenics in brackets. So the problem with the client is that the client keeps defaulting out and he now refuses to eat or to cooperate with the caregiver. The client is now bedridden and the disease is advancing. Our main concern is that there is no clear reason why the client keeps defaulting out. With the caregiver feeling burdened, the client is at risk also of being neglected, because the caregiver verbalized that he is also feeling frustrated that the client is refusing to eat, is refusing to cooperate in any way with his care. So the chief complaint is that the client is bedridden due to the advancement of disease after defaulting on ARVs. He refuses to eat, he refuses to cooperate with his activities of daily living. The caregiver complained that he is feeling burdened and he is also frustrated about the client's condition. Also, because the client's mother is reluctant to assist the caregiver because the client's caregiver is his father. So I think, as we know, with males and people who are sick, there are not that much of good caregivers. So that's why the father verbalized that he is frustrated, especially because he doesn't understand why a 27-year-old person would just stop taking their medication without any evidence. On assessment, the client is emaciated, is also dehydrated, his lower limbs are ankylosed, and the tongue has quite patches and exudates on examination. They are covering almost the whole mouth with also the side of the cheeks. The client's voice is very hoarse and shallow. I would say the voice is not audible at all, because even when we were communicating with him, he had to face us so that we could try to be read in order to understand what he was saying. Otherwise, communication with this client was very difficult. And he also has flaky patches on the skin all over the body, has limited range of motion, but his respirations are normal. On medical history, the client has been on ART since 2008. It means he was just 11 years old when he started ART. Currently, he has defaulted ART 3 times despite having stepped up adherence counseling from the clinics and hospitals he has visited. Also, the client was very sickly as a child, such that at one point in time, his skull was exposed as he had an infection or a wound, according to his father. He had an infection or wound which was neglected, and he hadn't been taken to hospital because at that time he was staying with his mother. So his mother is a heavy alcoholic, so she would just neglect the child. And also the child didn't know his parental home, his father's side of the home, so he was staying with them. And also sometimes the client uses herbs for treatments, and when he's using the herbs, he stops using the heart. He's got no history of TB. He's had a spinal lumbar puncture done for further diagnostics, but unfortunately, the family didn't have the reports for any results if they reported them yet. And also for the medical history, it was lacking because the chronic care file, the green book, was missing. The family said they don't know where it is, and also the client doesn't tell them where the missing file is. So we couldn't ascertain CD4 count, viral load count, and all the information you can get on that file, which is important on the client's treatment. On the social and family history, the client is unemployed. His father realized that even if he does get employment, usually he just works for a few days, then stops. His last job was as a security guard, in which he just worked for 2 days, and then he collapsed quite on the job. So that was the last time he attended work, and since then he has been in and out of hospital sick. With education, he ended in Form 4. The caregiver also verbalized here that he tried to take the client back to school, but the client decided on his own to stop going to school. With the socio-economic class, we rated on lower class. The client is single with the lifestyle habits and history of taking alcohol. With the relevant conditions in the family, there were none that were significant, except for that the child, as I mentioned earlier, the client grew up with his mother, was reputed to be a heavy alcoholic. Then proceeding with the advanced directives, none were done, and also there was no agreement that was done. The healthcare policy wasn't assigned because we had difficulty communicating with the client. With the mental status assessment, the client appeared well oriented, but with the concerns, we couldn't do a proper assessment with the orientation because we had a problem with the communication due to the client voice. But we could see that he understood what he was saying and he tried to respond. It's just that the voice wasn't coming out, but the client was speaking. So hence I felt like he is well oriented. With the review of systems, the vital signs, the temperature was 36.1, the blood pressure was slightly low at 84 over 64, and the pulse was 101 with respirations at 18. We couldn't do the oxygen saturation since we didn't have this meter. Then for the pain score, he was rated a test scale of 4 out of 10. We used the numeric scale for assessment. And also his eco functionality score is at 4, which means he is most of the time trying to bed and to his ADLs at home. Then with the symptoms he had the presence of pain which was mild. Also we felt that we cannot rule out depression, but we felt that we could at least rate it at mild because with such a condition, no one can say they are not anxious or depressed about that condition. And also he did verbalize that he feels tired most of the time. And with the cough appetite, anorexia, which we rated at 1, and also dry mouth, which was mild. And the patient is overwhelming ability because he cannot move at all. His limbs are ambiguous. With the medications, since we didn't have much of information from anything documented from hospital, but we did get from the caregiver that he was on tenofovir, lamivudine, and also he is currently taking the same regimen for it. He also has got multivitamin for the anorexia, vitamin B for EG, and we also prescribed him paracetamol since he complained of pain. Then with the pain assessment, he reported that he has pain on the lower back, lower spinal back, which was acute. He said it is aching and he rated it at 4. And he said it is constant. It was precipitated by the fact that he is mobile. And he said he gets better when he tries to rest after taking medication. Well, he did say it affects both his sleep and mobility. And then moving on to the second type of pain, he also said he has pain on the neck center just by the thyroid. And he said that the pain was acute. He also said it's aching, rated at 3. He said it's constant, it is caused by swallowing, and it is relieved by nothing. He said it's just always constant. He said it does affect his sleep and mobility. With the effect of the current medication, since it was just as prescribing paracetamol at the time of the visit, so we are yet to assess how much of effect the paracetamol had, if it did have any effect. And can we also note, colleagues, with the pain assessment that we couldn't do it as thoroughly as we would have liked to, because the client could communicate very well. So with the pain evaluation form, we evaluated the client, or I'm sorry with the date. I'm sorry with the date, but it was 14 March 2023. And the pain was on the lower bracket scale of 4, which was left. And he is headed for 3 weeks. The possible cause could be the lumbar puncture he had before being discharged at the last hospital was admitted in. When that was the caregiver's assumption that he is also thinking it was caused by the lumbar puncture. So he had into the pain. He is due for review on the 27th of this month. So we couldn't do focus lab investigations as we don't have any treatment facility. And our further plan, most of the plan we had, it was to continue from what we've already done. So hence, I've written that we will continue, we will encourage the caregiver to continue assisting the client with activities of daily living, especially with the nutrition, so that the client can recover quicker. And you also provide the stable adherence counseling to the client once he is able to communicate properly, to also understand his reasons for defaulting, especially so many times, and also to provide with client with those hygienic items which we have available, like the linen savers, and to also continuously assess pain and properly manage it. We will also address issues of spirituality, the client's spirituality, as the caregiver verbalize that the client, he uses different churches all the time, and sometimes when he goes to a certain church, it's like he's told that he doesn't need the medication, or he has been healed in some way. Hence, he starts the episodes of defaulting out. And also to continually address the client's social issues through the social worker's office, inclusive of trying to contact the client's mother, so that at least maybe there could be a plan how the mother can assist the client's father with the client's management. As the father did say that he now cannot even go to work or anywhere else trying to make money for the family, since now he is the breadwinner. So now he has to take care of the client, and also to acquire more information about the client, especially with the tracing of the green book, so that we can be able to know his before count and viral load, so that we can continue with proper management and clear when necessary. So that is our client for today. Can I remind you all colleagues that our main concern is that we don't have a clear reason why the client reports out, and we would like assistance with how to properly approach such a client in order to encourage him to take the act for his own health. Also, the fact that he now has a child who is less than 2 years, and also with the child having grown up being neglected, it seemed to us as if he had probably anger issues of being neglected all along while growing up, and also growing up being now HIV positive. Maybe he feels it would have been better if he was the one who had acquired the HIV on his own, but unfortunately for him, he was just born with it. And also to at least assist with ways, or a proper way to try and contact their mother so that she can be able to assist. So that is our case for today. We are welcome for any contributions.
Thank you, Nonduduzo, for the case presentation, and thank you for the way that you have actually taken care of the client. So as she has mentioned, colleagues, this is the time for us to actually make recommendations or any questions that we would have about the client or the case presented. We can use the chat box for any questions or comments. We can also use the raise of hand.
Okay, thank you. Maybe I'm interested in this case. I don't know. It's just a challenge. Maybe I thought Zinhle will take us through in terms of because you may find that these are psychological issues. Maybe the patient is considering taking or stopping taking the art as a way of revenge or as a reaction towards him or towards my parents' arc. So I don't know how psychologically such a patient can be helped when she cannot now verbally express himself. I don't know. Maybe those doing psychology can then help us in such an issue. Yes. So I don't know how best we can help such a patient when now the patient has these anger issues but cannot then respond. How can we help the patient to avoid maybe suicidal acts? Secondly, is the issue of spiritual hunting. I don't know how we can help in this situation because it's like the church has been telling the patient that he's healed, but then the health system is telling the patient that you still need to take art. Maybe if we can advise our nurse on that issue, on what she can do. I don't know.
Thank you, Mr. Mashamu. There is also a comment from Zinhle, where she's responding by saying, I think the patient has got anger issues, and then CBT and support therapy can be of help. I'm not sure if I'll be putting you on the spot, Zinhle, if you could maybe care to elaborate a little bit further on the issue of cognitive behavioral therapy and the support therapy.
Afternoon, colleagues.
Yes.
I'm sorry, my network is not right. So we found that becomes Puma then. But according to me, I think maybe doing home visit will help, maybe, or having time with the patient, find out like we would say how is he feeling with the situation, because you'll find that the patient's got anger issues maybe towards the parent or whosoever, and maybe the partner, even the partner as well, because we don't know, we would see how are they coping Kaya. So I think by sitting down with the patient, you'll find that the patient has more to tell you as a healthy care worker. That's why he keeps on defaulting from the medication. Even advising the caregiver of the patient, maybe to be with the patient, and maybe have quality time talking about the situation, just to normalize the situation. Because I think you may find that the patient is vulnerable, although the caregiver or the parents are there, but they do not give him the much support or the love maybe he or she wants. So I think by doing that, you'll find more, maybe if you can talk, discuss the condition with the patient.
Thank you so much, Zinhle. I believe our nurse has taken note of what you are saying. I don't know if there's anything that she wants to say or add on that.
I think it would be to thank you, Zinhle, for your contribution. We will definitely use your advice and try to also talk to the caregiver to be able to at least be with the client until he gets better, so that we can get deeper into the problems. Thank you.
Thank you. I am seeing a hand from Trustee Mamba. Kindly unmute yourself. Mbata, sorry. Trustee Mbata.
Thank you so much. This is just an interesting case indeed. I just want to ask that, as they have said that maybe they can visit the family. I'm asking that, is it not possible to involve in with the counseling? I think the counseling just for the whole family should be included. Another thing I want to ask that, for such a case, is it not possible maybe to even refer the client, I don't know, psychiatric, for further assessments, psychological or mental assessment, something like that? Maybe they can go deeper, and identify some things maybe that the patient can even ventilate to them. But it's just about counseling, involve the family, like counseling.
Thank you so much, Trustee. I think what you're mentioning is very important, not leaving the family behind. For the time being, the client is currently bedridden, so it is quite difficult for him to move around, and where they are staying, they struggle to even, I think, get to town because their roads are so bad. So for now, we were conducting the home visits. We were seeing the client from home. And as mentioned earlier, the client was struggling to communicate because his voice was very hoarse. But we are taking note of what you are saying, and we are definitely going to implement it. Thank you.
Yes, I see a comment from Zinhle. She's sort of saying, if it's possible, can I have time with the client? And then he said maybe referral of the family and the patient. You may find that they also have psychological problem. I don't know if the possibility of time between Zinhle and the client.
All right, thank you, Zinhle, for that point. I think that would be very good, especially even with the mother, even if she is staying far away from now. But I feel that she also does need that psychological session, because maybe that's why she is such a heavy alcoholic. Maybe she's trying to run away from certain issues in life. Also, the father does need the counseling session. The only problem for now, as Nancy mentioned earlier on, is that the client is being taken care of by the father. So now even the father cannot go away even for a day, because the client will remain at home. And also where they are staying, it's quite far. But I am thinking that once maybe the client has slightly recovered just enough for easier mobility, or maybe once they are able to even bring him to a facility, maybe with private transport, then maybe we'll be able to contact you to arrange that appointment for them, as I feel it would be very much important for them to have a session with you. Thank you.
Yeah. Maybe another thing, maybe I think maybe if Zinhle, you can be available for home base. I think the regional nurse can provide the transport, so you can go with her to the patient and the family. I don't know if you can be available for that.
Thank you.
Yes.
She's gone.
Sorry, colleagues.
Yes.
Yes, sorry, colleagues. I think we can arrange that. I'm always available, but we can arrange the time maybe and the day.
Thank you. Thank you so much, Zinhle. This is so much appreciated. We are always looking forward to working with you, colleagues, receiving support from you, and this is very, it's actually very motivating. So thank you. I don't know if we have any other, and I think we are going to come back with this case, colleagues, to give you an update on what is going on with the client, even maybe after Zinhle's visit. Do we have any other questions or comments, colleagues, on the case?
Yes. Okay. I'm also interested, colleagues, on another issue that I had. How best we can support a patient, maybe in terms of, you see, this patient, Eswatini, also shared that the patient has been going through church to another, and though she never revealed the type of church, but it's good that the patient relies on Church of God for future and hope. But then I heard that the patient was told that she has been healed from the HIV, and then the patient was told that even if he stopped taking the medication, is fine. That my question is, how do we then help such a patient who has been told in hospital, you are HIV positive, lifetime medication, if then there is a church behind the seat? Maybe they've told him even it's not HIV, we don't know. But then now it's a conflict of interest. How best we can, or we will rely on the psychosocial. But I was asking on a spiritual perspective, because we cannot take away the patient from what he believes in, but how can we redirect such spirituality to be working for the patient, if possible?
Please unmute yourself, trustee.
Thank you so much. On addition, I heard Tanin mentioning that the patient that is sometimes taking herbal treatment. I wonder who's providing this client with this herbal treatment, Jack?
Thank you, sister, for the question. When we got the information from the caregiver that once the client feels fine, he usually leaves home unannounced, and he goes to stay in all places such that the father usually hears from community members that, oh, we saw your son in Punya, or now we saw him in Babane. So also the father doesn't have the full information on where does the client acquire the herbs. He also got to know of them when the client got sick, when they were going through his clothing bag. So that's when the caregiver came upon the herbs. And also the caregiver with the churches, he said is in and out of church. He just said Lamason Abu pastor, so he doesn't know which church exactly. So I am also thinking that maybe once the client is able to communicate, he will be able to answer all these questions we have.
Thank you, Non-Dudoso. I don't know if we have any other questions for Non-Dudoso. Any comments, colleagues?
Sorry, colleagues. Can I please comment on the issue of pastors? It's
Please.
not like I'm against Christianity, but I think pastors also need to be educated in as far as medical ethics are concerned, because most of the time I also had a client, a learnable issue of pastors. Pastor said, if you use this anointing oil, you'll be okay. Pastor said, so I think they also need to be educated, because bayaslimatela my client most of the time. You find that because my pastor says I need to maybe get away of this medication and I will be fine. Maybe if I can drink this concoction, I will be fine. Yet that is not true. So I think pastor also have psychological problem. I don't know how I can say it, but I feel like also pastors needs to be educated because client.
Thank you, Zinhle. And what you're saying is actually very true, because in most cases, spirituality is very important to each person. So you find that the client now holds on more to what has been said by their spiritual leader or pastor over anything that the doctor or maybe any lab results will say or present. And we find ourselves struggling to convince the client. But whenever or let's just say, even if we didn't get the chance with the pastors, not to say that we are supposed to leave that out, but when working with the client on such issues, we do not come in hard on them, because you might find that the client now shuts down and they are no longer able to receive any maybe support or help from you. So whenever we tackle spirituality issues, we need to be very sensitive. But I think what Zinhle is saying about maybe educating or involving pastors in healthcare can be very much helpful moving forward, because as we work with the pastors, it will make certain things easier, and even in terms of maybe costs, because you find that they buy these anointing oils, they travel to go and see this pastor, which is very costly for the client, and at the end it won't be helpful. So thank you for bringing that up, Zinhle. There's also a comment on the chat box. Can I quickly read it? From Mage Gametse. It says, team, for the spiritual hunting, we have heard that the client is no longer mobile. On that note, is it possible to get a spiritual leader who is objective to talk to the patient and family? If the patient is willing to be done a rapid test in the presence of the spiritual leader, then the two can be discussed on the day in his presence, giving information with facts. If the patient can write, then he can be given an opportunity to respond in writing.
Yes.
Thank you, Mage, for that recommendation. I'm not sure if there's anything that Tani wants to say on that regard.
It would be to thank Maria for her contribution. I think we will try to do that. It's a very good suggestion.
Thank you, Nonduduzo. Looking at the time, colleagues, I think it is safe to move to our didactic presentation. But if there are any other comments or any other questions that we still have on the case, please feel free to write in the chat box. We will always check the chat box to see if there's anything shared or written there, and we'll respond to that question or comment written in the chat box. So Mr. Mahlangu will be taking us through advanced conversions and opioid side effects for today's presentation.
Okay. Thank you, team. Thank you for such a wonderful case. Actually, thank you for Mike Amas to reveal the other mode of communication. It's a bit a challenge. This is one of the things as colleagues we need to try to work on in our facilities, to wait for a long time to engage our clients until their communication ability is a little bit compromised. So that's why we are also always saying, let's initiate palliative care from diagnosis to avoid such issues. Once we start on a rough base in terms of communicating with the patient, you find that it becomes so expensive to manage when then they are progressing with the disease. So we are encouraging that let's try by all means that when we're breaking the first bad news concerning the diagnosis, we do justice on that point. It will save us a lot of time, a lot of money, a lot of soul, and a lot of energy. Not as all the patient and the family, they will benefit from that. I think if we can try to push ourselves every time and again, that every client that comes to me that with diagnosed with a life-limiting or threatening condition, I do justice on breaking the bad news. You'll find that if the patient has got them well and well taken care of, he will not even fall at vulnerables to such people who will give him a false hope. You find that the patient, instead of getting help, he will die. But in this case, the alternative is going towards communicating in terms of writing. I think that one can move. I will encourage Eswatini to get his notebooks and a pen and a pencil so that the communications will be verbal and in terms of writing to extract more information from the patient. You will discover that even where he is not interested to be there. So yeah, there's a lot, but let's continue for today. Last week we were looking at an introduction or to how best we can do conversions of opioids. But today we are saying now we are looking at the opioid conversions when now we are looking around side effects. These are the things that we will face every day, or we face every time we are meeting with our clients. So we will look at how to convert the single opioid when patients are in multiple opioids and multiple routes of delivery. We'll learn to know that. We'll also understand how to recognize the signs and symptoms of opioid ineffectiveness and toxicities, and we'll be able to manage opioid toxicities and side effects, including how to discontinue opioid therapy via safe tempering over time. We'll also look around, utilize equivalence conversion tables for safe opioid rotation. We introduced the tables last week on the tables how to move and the principles on how we move around. So we won't dig much on it, but maintaining the use of a consistent opioid agent reduces the complexity and the risk of poor pain control and side effects. So this is very important to be consistent when using opioids. There's no need to use IV analgesic or IM analgesics in a patient living at home who has controlled pain and who is able to eat and drink. So we then go for the principles of opioid administration or analgesic administration, of which one of it is by the mouth. So there's no need to go for IV, or especially at home. And then, so there are indications for opioid rotation. Why should I move from morphine to hydromorphine, or move from morphine to tramadol or oxycodone or fentanyl? There are some consideration here. So maybe if we can select those that we feel they can be applicable for you to move from one to another opioid. I will give you just this a minute to read it through. When should we? What could be the indication to rotate a different opioid? So can we select the one that we think you can apply? You can write it on chat, the one that you think can be applicable, or you can unmute and say, I think ABC, or which one do you think can be used for, you can consider as an indicator for you to swipe or change an opioid. You can write and chat, or you can unmute and say, I think A, B, C, D. Which one do you think can be one for switching? When can you consider moving from one opioid to another? Or in our facilities, have we ever convert patient? Yes, Tani.
I'm not sure if I am correct, but I am thinking that it could be due to intolerable side effects. Because when we are giving an analgesia for D, we are expecting constipation, and constipation can be controlled or can be managed. And we cannot also give an analgesia according to the client's preference. And we can also not change an analgesia due to poor analgesia despite titration. Okay, so I think I read that. I didn't read that well prior, but I'm thinking it could be due to intolerable side effects.
Okay. Okay. I see also someone saying C. Anyone with a different answer? What indicators can say, no, I need to rotate this patient? One is a C, intolerable side effect. That's correct. Okay. And then another one is the poor analgesic analgesia despite titration, right? If the patient's pain is not relieved, despite me titrating the drug, it means I need to convert, right? So those are the indications. So inpatient preferences alone are not an indication for opioid rotation, because the patient will say, I need the injectables, because he wants to enjoy how it feels like, you see, so we cannot use that one. But constipation is a universal problem, and it's a problem that we need to do in terms of prophylactically or proactively, regardless of the opioid choice. So we need to always prevent opioid nausea. And then I have another one. Which of the following are common reasons for needing to rotate to a different opioid? Those are indicators. If I see there's this poor analgesic or this, but then now, what could be the common reasons that there's a need for me to rotate to a different opioid? There's neuroexcitability, hyperalgesia, tolerance to an analgesia, inadequate absorption, adverse side effects of initial opioid, interpatient variability in response. So which one can I say, this is my reason I'm moving my patient to the other one? Yes, you can type on the chat. Which one do you think can be the reason for needing to rotate to a different opioid? So now, once there's this, I might move my patient to a different opioid. Yeah. Whether it's in a hospital or in a home-based care setting, no, I need to move my patient to another opioid, which could be the common one. Have you ever moved a patient from one opioid to the other, from tramadol to morphine? From morphine maybe to hydromorphine, to fentanyl, you know. Which one do we know? The most common I know, we normally move patient from tramadol to morphine. Which one? Tanya, you have something to say. I'm also looking at chat if anyone is saying anything in terms of the need.
For me, the most common reason is the adverse
Yes, that's correct. That's correct. When the adverse effect, I need to move. This was the initial one, but it's not working. I move my patient to the other one. Anyone else with a different view? Except adverse effects, which one? Or we all agree now, no, when the adverse effects, we need to. Okay, so the answer is ACD. Where is it going? The answer is ACD. The other one, the only tolerance, it's rare that you discover that now because of tolerance, I have to move you, right? But all the others, hyperalgesia will look at it closer, the inadequate absorption. You cannot keep on giving a patient a drug that is not well absorbed, right? So I'll then move it away. Okay. And then the response of the patient. How is my patient responding to the medication? If not responding well, then I'm gonna shift. All right. So those are the ones. Tolerance, legally, it's a rare case that you will find that they are not. Okay. Okay. And then I have the reasons for opioid ineffectiveness. Okay. Yes, Mbata. I see your hand.
Thank you. Can I take you back to the first question?
Can we go back? Yes.
Yes. Yes. Okay. I just want at least. Can you please just briefly satisfy titration ukuthi sekanjani? I'm just still learning nana ngalaga palliative. Ukuthi kusuke can you just please briefly describe that points, poor analgesia, describe titration. Because maybe I'm thinking that when I think about it, that's me, I think that maybe the patient, you find that even when you try to reduce the pain or relieve the pain, but the pain is still not tolerable according to the patient. And I think maybe there's a time like who cancer patients where you find that they even, when you can even change the medication, the pain they say is still there. And so I'm left behind a little point.
Okay. I think as we go, it will be more clear, but let me just say, when you talk of analgesic titration, we know that one of the reasons we go for opioids is because most of the opioids, they are good in terms of managing pain that is severe. So, and they've no limit, especially in terms of morphine. There are those that have limited, you cannot reach this level. So every time you start an opioid, you start from a little bit lower dose, and then you titrate it based on the need of the patient. There are those patients you'll find that even when you are titrating the drug, but it's not responding to it. For example, I will give tramadol 50 milligram, and then later they go for 100, and then you discover the one is 100, that's the maximum I can go, because more than 4 times of that, it's 400, that's the ceiling. But then for morphine, I can titrate as much as possible as I can until I reach the level, or until the patient experience side effects. You will find that even if you are titrating the drug, but the patient is not responding to that. So that's what we are calling titration. So there's a formula of titration. Titration sometimes is informed by the issues of breakthrough pain. And then there are many factors behind that also to say, maybe the patient, how is the patient taking the medication? Is it the optimum dose? And the issue of, there's also that consideration of, before we think of titrating and stuff, we need to consider the issue of, we titrate until we reach the level whereby it's working. Once it's working, we switch to long term. You'll discover that the reason the patient is not experiencing analgesia is because the patient is on short-acting drugs only, and it's working for a shorter period of time, and then the time frame to take the other dose is when the other dose is finished in the blood. So you will find that the patient is like that. But once all other issues are sorted, and then the medication was titrated from one dose to the other, but still not reaching the optimum effect, then we say, no, let's switch from this one to a little bit stronger one to see if it will work. I think that's what we are saying when we say you are not achieving the effect, even if you are titrating the dose as required. But then if you are not achieving the same effect, that's it. But then you need to eliminate other weaknesses around to say it is only based on the drug other than other factors around. Maybe it's late taking of the medication, then we need to sort that issue first. Then we can say the person was not responding very well. We were not achieving pain control regardless of titration. I may say that's what we mean when we say poor analgesia despite the titration being made. Otherwise, under normal circumstances, when I'm titrating, at some point I must reach a maximum whereby then the patient will be having a well-controlled pain. Okay, I think.
Thank you so much. Thank you. Yes, thank you.
So there are reasons for opioid ineffectiveness or toxicity. One is accumulation of toxins in the metabolites. Toxic metabolites in the body is hyperalgesia. So increase in pain and poor response to opioid titration. That's what we mean here. Hyperalgesia is usually associated with symptoms of neuroexcitation like breathlessness, anxiety, agitation. So you will find that there. Or allodynia, or increasing sensitivity to non-painful stimuli. Yeah, that patient is no longer responsive. So now it's sensitive, even non-painful. The charge, patient will cry like never before. So we said that allodynia. Then the mechanism of action is uncertain, but maybe due to the accumulation of opioids and toxic metabolites. So that one also would lead to accumulation of toxic metabolites. Then you find the patient not responding well to opioids, like especially find patients on kidney failure. At some point, if they're not taking the dialysis, like the pain is undescribable. Progression of the disease, the most common reason for worsening pain on a previous stable opioid dose is the progression of the disease. So also that one make the opioid not ineffective. So that one you also have to eliminate that one to tell that is it opioid related only now. And then another issue is the new pain type. You know, all alone you have somatic pain, somatic pain, but all of a sudden you have another different type, like arthritis, diabetic neuropathy. You know, you have developed different types of pain. We were used for you to be using this drug, and then all of a sudden you are developing another type of pain that will need us to re-strategize in terms of management. That also will make the opioid that is already been used not be effective. Another issue is the intolerable side effects. You know, it does limiting opioid toxicity like sedation, delirium, and hyperanagesia or nausea. You know, I'm giving you this opioid, but now you are developing some certain toxicity. Maybe now you are becoming more sedated. Now I have to choose between reducing the dose so that you are less sedated, and then there's this type of pain that is, you know, the intolerable side effects also make the opioid not to be effective. And then the failed route of administration, like poor oral absorption due to bowel dysfunction and diminished transdermal skin absorption, like for those who are doing patches of opioids due to adhesive failure to or patch placement on a scar tissue, like now we have developed wounds and all over, we can put the patches there. So also the failure of administration, like the patient now cannot swallow, you see. If the patient cannot swallow anything, then now it's a challenge. We cannot give you tablets long acting, then it's a challenge. So those are the things that sometimes they contribute to opioid ineffectiveness. Another issue that we normally exclude and not think of is psychological, social, and spiritual factors. Those are the big elephants sometimes behind the scene that make opioids not effective. You'll be given a patient morphine, you'll discover the issue is not the morphine, is a husband that is abusive behind a sick patient. So spiritual, existential issues, social issues, psychological sources of suffering may be expressed by the patient and physical pain. So we need to do thorough assessment. That's why when we started, we talk of total assessment, like what our founder of palliative care, Cecil Saudas, described, multifactorial suffering as total pain. We discussed it when we started this series on pain assessment, that we need to do total pain assessment, because while we are dealing with the other issues behind, we need to deal with psychological, social, and spiritual factors. If they are not dealt with, you will find that the opioid is ineffective too, again. That's why we need a multidisciplinary team to work on this. We cannot hide behind the morphine. We need more. So what is hyperalgesia? Hyperalgesia is a poorly understood syndrome of worsening pain and agitation despite increasing dose of previously effective opioid and analgesics. So that's what it's all about. So among risk factors for this one, they include total daily dose of greater than 200 milligrams of oral morphine equivalent. So now we are taking more than 200 milligrams of morphine. Now we can begin to suspect there's hyperalgesia here. Dehydration, that's why we promote our patient to take more fluid, because once dehydration happens, you may have this. Renal dysfunction and associated accumulation of toxic metabolites. Issues, functionality of kidneys, also Dr. Smetlana emphasized on these issues. Functionality of the kidneys is very key, including the liver. They need to be functional. Once the kidneys are not working well, they try even morphine, they will say change from morphine to hydromorphine because of the kidneys, to avoid hyperalgesia there. Use of maybe other drugs like will improve neuroexcitability and seizures risk. Also, they put the patient under hyperalgesia. So that's why some drugs like meperidine have been stopped, because they put the patient to that. Maybe another thing or another brain teaser we need to have, or what are the correct action then to take when my patient is suspected to be on hyperalgesia. Do I need to rotate to a different opioid? Do I have to stop the therapy? Do I have to hydrate to consider the interventional pain approaches? I don't know what you can say. What can you do? Now we have a patient who's experiencing hyperalgesia. What can you do? Can you rotate to the different opioid? Can you stop the opioid therapy? Can you hydrate or consider interventional pain approaches? What can we do? If your patient presented with hyperalgesia problems in your facility or you find them at home, what can we do? Maybe you can choose a letter and write on chart, or you can adjust mute and shoot up. What do you think you can do? Here is a patient who is experiencing this. I can hear Tam saying, I will rotate to a different opioid, and that's correct. Because the patient is developing hypertension, and this one, especially if it's morphine, maybe due to kidney failures, I will rotate to hydromorphine. Another issue we mentioned under the factors of hypertension is dehydration, right? I will hydrate my patient. You see? And then I will look for interventional approaches. Maybe I will look for radiotherapy. I will look for what is saying Sister Mbata is correct. I'll go for ACD, right? Because stopping the therapy will result in withdrawal symptoms there and will not address the patient's pain, right? So I cannot withdraw the drug. I better look for another alternative. Okay. So another one is that we need to do opioid rotation. If I'm doing opioid rotation, for this instance, I'm having this kiosk patient who is hospitalized, a hospice swing bed for hydration and pain control after she's diagnosed with hyperalgesia. Your next step is to rotate from morphine to a different opioid. Which one do we choose? We will choose hydromorphine because it is so friendly to the kidneys. So these are the things we need to know. Hyperalgesia can be caused by the accumulation of toxic metabolites associated with high opioid doses. So we need to know there should be maybe high dose. Then I have to check. If the patient presents with these symptoms, I need to check how much dose is the patient taking on a day. If it's very high, I will suspect the patient is on hyperalgesia. Dehydration or insufficiency, renal insufficiency. If the patient is dehydrated, the patient has high dose, or there's renal problems, then I will consider hypertension there. Hydromorphone is both oral and IV inhalation and wide safety margin and therapeutic window in renal disease than morphine or oxycodone. So I will not go for those ones because they are not good in terms of the kidney. So, and it's better to be administered maybe in a facility like in a patient, in inpatient units. Hydromorphone is generally the opioid of choice for rotation in the context of hyperalgesia and renal dysfunction and dehydration. If that's the indication, then I will move towards that one. Oxycodone is associated with accumulation of toxicity with prolonged use in renal insufficiency and cannot be used in the IV form. So that's why we cannot go for that one sometimes in an inpatient. But then the issue is, I'm sweeping my patient to tramadol. No, tramadol is a little potent, only a tenth of what morphine could give. So you need to give them 10 times the dose of morphine to achieve the same effect. Then you will easily hit the ceiling of tramadol without reaching the same effect. So sometimes moving from morphine to tramadol is not effective. That's why then we say we better go to the nearest opioid. Then another opioid convention steps that we can take when we mentioned this one in our presentation last time. That first of all, I need to get the total morphine equivalent. I need to know when I'm moving from morphine to another drug, like this table extracted from a Kafka. So there are different tables. So you need to know the equivalence. If I'm having such morphine, how much will I require to give the same effect from another opioid? Then I am able to convert. I need to convert that one first. Two, I need to convert to an equivalent dose of the total daily of the opioid. So like, how much will this be equal to hydromorphone, or how much will be this equal to fentanyl, how much will be this equal to a tramadol, depending where are you moving to. Then you account for incomplete cross tolerance. Last time we said, when I'm switching from tramadol to morphine, I need to start morphine from the lower dose. When I'm moving from morphine to hydromorphine, I need to start from the lowest dose of hydromorphine, so that I also include the incomplete cross tolerance. You find that there's still morphine in the blood. Then when I'm moving, I need to consider that one. Then I will titrate slowly while I'm going up. So those are the things we need to look around when I'm converting. Then if I'm looking around incomplete tolerance and hypergesa. So if a patient is likely to have hypergesa due to accumulation of toxic metabolites of morphine, dehydration, or declining renal function, you must reduce the dose by more than the standard amount when accounting for incomplete tolerance. For example, the patient will require morphine 10 milligram based on the conversion from tramadol upward. Then I will go down a little bit, 50% to 5 milligram, then start from there. So I can watch if the patient will respond very well to the new drug. In the context of hypergesa, always adjust for incomplete tolerance by 50%. I've already said that. Adjustment for incomplete tolerance in the context of hypergesa reduces the patient's 24-hour hydromorphone dose by 50%. If the patient was kidney related, I'm going for hydromorphone, so I'm going by 50%. So it is important to treat the expected opioid side effect of constipation. Always when you're giving patient opioids, remember that there is a side effect called constipation. So what are the principles of opioid rotation? Use an equinalgesic table to see if you're moving from other to other, how are you going to balance the drugs? Adjust the dose to account for incomplete tolerance. When you have found it up, then adjust it by reducing by 50%. Monitor the frequency. Maximum week between the visit, then closely for analgesic response and side effects. We stated that when you are initiating opioid, you don't initiate and go. You monitor the patient because you might find the response is negative and the side effects are worse. So consider waiting for tolerance to develop to side effects, especially patient will be initiated on morphine. They will develop nausea and they will say, this thing is sedating me. They will say a lot of things. Such side effects, you'll find that they subside within 3 to 5 days. So wait for them so they develop the tolerance. And treat side effects rather than switching the medication. If the patient is nauseatic, so better give antiemetics, and then for 3 days, you'll find that it subsides. If it's sedative, and then at least reduce a little bit of the dose, or wait until 3 days, cut down and see if the patient is responding that. The reason is that even Dr. Smethana mentioned it last time, that the challenge is that if you are switching the drugs, you are going to an unknown drug and you don't know how the patient will respond. So it's better the one that you know now than the different agent you don't know what it will do for the patient. So consider evaluation by palliative care or pain specialist for patients who experience opioid ineffectiveness or persistent intolerable side effects. If your patient is continuously nauseatic or vomiting for a long time, then consider consulting physicians or specialists so that they can see what could be the problem. And then when we talk of tolerance, which describes a long-term adaptation to opioid exposure that causes one or more opioid effects to diminish over time at a given dose, right? So tolerance typically develops rapidly to sedation and nausea, hours to days. We find that people have developed tolerance very quicker, but rarely for analgesia and never for constipation. There's no tolerance for constipation. It's always there. Never say, no. So why try opioids? I'm never constipated. There's nothing like that. It will always be there. And if you are not going to manage constipation, you will have fecal infection. You will now need more money for operation. So it's something we can prevent. So tolerance to constipation never develops. Constipation is a near universal consequence of opioid therapy, regardless of dose or duration of treatment. Don't say I've given the patient a little dose. Once you prescribe opioid, always consider constipation prophylaxis. So you anticipate for it and you treat for it. So managing opioid side effects is if tolerance does not develop after several days. What do I do? There's no tolerance for sedation. 1, dose reduction is the first thing. 2, then add adjuvants. Once I've reduced the drug, for example, a patient with neuropathic pain, it is recommended in our palliative care guidelines that you can reduce the dose and then you give amitriptyline. You see, you can reduce the dose and then you go for, especially if it's bone pain, you go for prednisone. You go for the adjuvants that will support the patient to keep that pain. So you do hydration and then you do psychostimulation, like you give the psychostimulant, so to help that patient. If side effects cannot be treated or tolerated, then you switch the opioids. You just run. If there's no sublimity, you do dose reduction, then you add antiemetics. You see, so if there's no output from there, you do what we call switch, or you consult. If there's confusion, it will happen, but sometimes it lasts for a few days because of the patient is still adapting or tolerating it. It's building tolerance towards the drug, the side effects. So if there's confusion, you do dose reduction, and then you add adjuvants that will support or keep the pain other than the drug that is sedated. Then you hydrate the patient. Then you put the interventional techniques like nerve blockers and radiation therapies. You know, we know these non-pharmacological measures. Sometimes we also add to help the patient cope with the pain. If it's not effective, again, you switch the opioid. Sometimes they complain of dizziness, you know, they cannot stand well, so they are complaining. Even then, you reduce a little bit of the dose, like we mentioned, 50% down or 20% down, and then you do non-sedating antihistamines. You look for those drugs that can help the patient to curb sedation, dizziness, and then you do the interventional techniques, other things I can use to deal with the pain other than the opioid itself, until the patient adapts. Sometimes they complain of itching. We don't encourage them to scratch themselves so much because they end up injuring themselves. What we do here, you reduce the dose and then you go for non-sedating so much antihistamines, right? So you look for the one that will not severely sedate the patient, and then you achieve the same. But if it's not still working because of the opioids, you switch the opioid for another one. And then if there's constipation, remember, it will never subside at any point in time, whether you reduce the opioids or you don't. The best way is to use prophylactic mode. So you will treat or you will prescribe the bowel stimulant. In our country, we use Senna or we use Besacodine, which will stimulate the gut system to move. And then the other one, we use bowel, or we use lubricants like lactulose, castor oil, or liquid paraffin, depending on what the patient can take. But the recommendation is combine the two to avoid the patient developing hives. We don't want them to develop hemorrhoids. We don't want that. So if you are stopping an opioid therapy, you should be discounting it is no longer needed, or if risk of opioid therapy outweigh the benefits of it. You don't just stop it. In these examples, the only relevant one where you can discontinue a therapy is A. B and C and D are not an indication for you to stop therapy, but they call for a multidisciplinary team in terms of their management. The only one you can say I'm discontinuing this therapy is when there is no pain improvement, or the pain has, when the pain has improved and there's no pain at all, so you discontinue the opioid. And then opioid discontinuation is opioid therapy cannot be stopped abruptly. You know, we need to do it tapping over time. So because they are high risk, there we don't want our patient to develop side effects. So these are the principles of tapping an opioid. If you're stopping tramadol, you're stopping morphine. The goal of tapping protocol is to minimize the adverse effects or the withdrawal effects. The patient has been on an opioid prescription, the longer the patient is on opioid, the longer the tapping period. So you go a little bit down. The recommended rate to taper is 20 to 50% per week based on individual factors, including time, particular opioid dose, and response to taper. How is the patient responding when I'm reviewing these drugs? Clear written and verbal instructions should be given for educating patients and family caregivers about the tapering protocol. To ensure accurate understanding and use of teaching back, use the teach back methods. Allow the patient to ask questions, ask them if they do understand what you are saying. Allow them to even repeat it to them. What did I say when I say reduce? This week you are giving 2, next week you are giving 1, next week you are giving 0.5, so they know how they are going to do it. Patients with substance use disorders should be referred to pain, palliative care, or substance use disorder specialists for supervised opioid taper. For example, in our country, we can refer them to psychiatric hospital so they can be monitored and be withdrawn. The bigger one that we can say we can adhere to, when I'm not sure, I need to refer to available specialists in my area or facility so they can safely convert the opioids or taper opioids and manage opioid side effects for my patient. Maybe in summary, when we are looking around conventional advocacy, whenever possible, maintain the use of consistent opioid agent to reduce complexity and risk of poor pain control and side effects. We need to adhere to that. Number 2, we have to, when changing the route of the same drug, it is not necessary to adjust for incomplete tolerance. If I'm moving from morphine tablets to liquid, there's no need for tolerance, right? Indications for rotation to a different opioid are inadequate analgesia despite up titration of the initial opioid or upper analgesia or interim side effects. When rotating opioids, use equine analgesic tables. Adjust to account for incomplete tolerance, and you need to monitor. Many side effects with tolerance does not develop to them. So even if you manage them, you ensure the patient is responding well to those side effects. Tolerance to constipation never develops. Always treat constipation prophylactically. Patients must be tapered for opioid therapy. Abrupt discontinuation can lead to life-threatening withdrawal syndrome. Thank you so much. These are the resources maybe you can read it through to get more information concerning this presentation. So thank you so much.
Thank you, Mr. Mashangu, for the presentation. I think we have touched on when, why, and how we can rotate or convert opioids. There is a question on chat box from Trustee on how to manage fecal infection due to opioid side effects or constipation caused by the side effects of opioids.
Yes. Okay, the first thing is prevention. We're using, but then once fecal infection is there, the doctors need to be consulted because sometimes you will give a patient the laxatives, and then the patient will release himself and say, "Ooh, at last." You will find that the stools that just bypass the blockade, and you will think you are done, yet the impaction is still there. So it's better then when it will be medically checked, scanned, and the doctors will then see if it will require surgical operation to remove that impaction. Otherwise, once it's developed, it's a serious complication, and sometimes it can become an emergency issue. So the best way is to prevent it at all. Otherwise, for constipation, we give laxatives, but the dual effect in terms of you give a stimulant together with a lubricant, not one of the two, but you give them both so that you prevent any of them happening or any constipation to happen. Either I don't want my patient to have fecal infection or I don't want my patient to have constipation. But then remember that when then the flow, the bowel movement are so high, don't give laxatives because you will kill the patient. Stop the laxative until the opioid will bring and normalize the bowel movement. And then again, you continue to prevent. But fecal infection is a serious complication that we don't want to see from our patient because then it's expensive to manage because now we need more resources to deal with. And once a patient has a fecal infection, you give laxatives and you feel relieved. You will discover that The stool has just bypassed the blockade.
Thank you, Mr. Masham, for that response. I don't know if there are any questions or comments based on the presentation. Do we have any questions or comments, colleagues, on advanced conversions and opioid side effects? It seems as if we don't have any questions. There's a link, colleagues, that has been shared on our chat box. It's a feedback link. So kindly click on that feedback link so that you can give us feedback on today's session. And if there's still any other questions or comments, please use the chat box to communicate with us. But looking at our time, I don't know if Trustee is trying to say anything. Okay. Looking at our time, colleagues, I think we have come to the end of today's session. Thank you so much for the contributions that you have made. We have learned so much from this session, and I believe you were able to pick a lot of important things as the session was ongoing. So please remember to click the feedback link. Our next session will be on the 5th of April, where we will be looking at special populations and patient control analgesia. So please join us for the session on the 5th of April, and please invite other colleagues to join in for this session so that we can all be able to learn and actually share information and ideas. So thank you, colleagues. I think we've come to the end of our session.
The materials of today's presentation will be shared in our iEco platform. It will be available at around 3 p.m. today. You can kindly begin to check our platform if you will find it there. So you will use your account and log in. You will access even previous materials, including the guidelines of palliative care that we have in the country that are there. So I think is that. Also, if you want to go back to the video for today, you can check it as of 5 p.m. today in our Eswatini YouTube channel. You will also find it there. But also the link for the video will be also available in iEco's back. Thank you. I can see Sister Mbata saying thank you so much for palliative care. You are doing really great. Thank you. From my side, bye-bye team. Let's meet next week when we will be looking at special populations and palliative control analgesia. We're looking around the special populations and palliative analgesia. We'll see how best we can maneuver the time. Bye-bye, everyone. Remember to click the link there before you exit.
Thank you everyone for joining. Please make sure that you fill the feedback form. Should I end the meeting?
We can mute. We can.
Thank you.